Good morning. I'll be talking about this article, randomized double-blinded phase 2B proof of concept clinical trial in early Alzheimer's disease with lecanemab and anti-A beta protofibril antibody. So this article was published in November 2021 in the journal Alzheimer's Research and Therapy Impact Factor of A. So following terminologies and we should know before understanding this. Alzheimer's, it is a progressive neurodegenerative disease causing a cognitive decline. So amyloid beta, it is the peptide that is involved in the Alzheimer's disease AD pathogenesis accumulating into plaques. So protofibrils, they are soluble intermediate aggregates of A beta considered highly neurotoxic. Plaques, they are insoluble A beta deposits in the brain, characteristics of AD. P tau, it is phosphorylated tau, a biomarker for neurofibrillary tangles and neurodegeneration. T tau, it is indicates overall neuronal damage. So lecanemab, it is an IgG1 monoclonal antibody targeting A beta protofibrils. IgG1, it is an immunoglobulin, and monoclonal antibody, it is lab made antibody designed to target specific antigens. Clinical trial, the phase 2B trial, it is a late stage exploratory trial to determine the effective dosing and preliminary efficacy. Bayesian adaptive design, statistical model that updates treatment and allocation based on ongoing results. ED90, it is effective dose of 90%. It is the simplest dose achieving more than equal to 90% of the maximum treatment effect. And response adaptive randomization. So in this study, adjustment of participants were done, allocation based on emerging efficacy data. Cognitive and clinical assessment terms. ADCOMS, it is Alzheimer's disease composite score. So it combines elements from several tests and to detect the early Alzheimer's disease changes. ADAS COG-14, it is Alzheimer's disease assessment scale cognitive subscale. It measures the cognitive performance of the individuals. CDR-SB, it is clinical dementia ratings sum of boxes. This assesses the severity of dementia symptoms. And MMSE, it is mini mental state examination. It's a general test for cognitive function. So these all tests were used for assessment. And biomarkers and imaging that was used. So PET SUVR, so it is standard uptake value ratio. So quantitative PET imaging metric for amyloid load. VMIR, volumetric MIR, it is MIR measuring brain volume changes like hippocampal and atrophy, etc. Neurogranin and neurofilament light, NFL. Emerging CSF biomarkers for synaptic damage and neurodegeneration. A genetic term which was used was APOE4. It is apolipoprotein E4. It is a genetic risk factor for late onset of AD, affects amyloid deposition and ARIA risk. So we'll talk about ARIA risk. It is amyloid related imaging abnormality. It is due to swelling of the brain observed on MRI in amyloid therapy. TEAE, it is treatment engagement adverse event that occurs during the treatment, and hemorrhage also occurs, micro or macro bleeds related to amyloid therapy. Statistical concepts to know here that they use was Bayesian probability. It is a probabilistic framework incorporating prior knowledge and current evidence. frequentist analysis. It's a traditional statistics using p-values and confidence intervals. MMRM mixed model with repeated measures, a statistical model accounting for within subject area over time, posterior probability that will estimate updated with the new evidence, and CSD clinical significant difference. It is a predefined threshold considered meaningful for clinical outcomes. So these are all the terms that were used in this study. The novelty of this study was it's a first clinical trial using a Bayesian adaptive design with interim analysis to identify the effective dose 90% in Alzheimer's disease treatment. Lecanemab is a unique in its selective binding to soluble A beta protofibrils, believed to be the most neurotoxic species of in AD. Hypothesis was that targeting soluble aggregated forms of amyloid beta, especially protofibrils, with lecanemab may reduce the clinical decline and brain amyloid burden in early Alzheimer's disease. So the aim was to evaluate the efficacy and safety of lecanemab in individuals with early AD, to determine the effective dose using Bayesian responsive adaptive design. Other objectives for this study were to evaluate whether lecanemab can reduce clinical decline at 12 months using the various scores, outcomes with 80 with more than 80% probability of 25% benefit versus placebo. Assessment of amyloid plaque reduction via PET scan, measurement changes in cognitive scales, that is improvisation was the objective. Analysis of CSF biomarkers and examination changes in hippocampal volumes using an MRI. So the methodology, the drug was the clinical assessment, ADCOMS, ADAS-Cog14 and CDR-SB, they were used. So biomarkers was used for during PET scan was CSF, A beta 42, p-tau and t-tau. The imaging was done for MRI using MRI for hippocampal and brain volume. Safety monitoring of regular MRI to detect ARIA adverse effects tracking, and genetic screening was done for ApoE4 genotype, which was considered due to ARIA risk, and it was a phase 2B type of study design, multi-center randomized double-blinded placebo-controlled trial. The duration of the study was 18 months, 856 participants, 854 treated, individuals with mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's dementia. Randomization was responsive, adaptive, Bayesian model, allocating more participants to likely effective doses over time, and placebo plus 5 lecanemab regimens varying by doses and frequency was given. Double-blinded, it was a double-blinded study, and so statistical analysis, primarily analysis was done by Bayesian interference with 80% posterior probability threshold for more than 25% improvement on ADCOM score at 12 months. Secondary analysis, Bayesian and frequencies approach at 18 months. The models used were mixed effect models with repeated measures of MMRM or frequentist stats. Significance nominal p-values was used due to the unmet primary endpoint. So the results of this study was the primary. They found out that the 10 microgram per kg bi-weekly lecanemab had a 64% probability threshold, which was 80%. Secondary endpoints after 18 months, amyloid reduction was significant, and the dose dependent PET SUVR scan decreased. The clinical decline in reduction was seen. In ADCOMS, ADAS, COG14 and CDR-SB test. Then CSF biomarkers, the A beta 42 was increased, P tau decreased, and T tau showed no consistent trends. The safety for ARIA, it was occurred in overall more than 10% overall, and mostly it was asymptomatic and resolved. So, following other discussions, the lenatumab showed dose-dependent reduction in amyloid and modest showing of clinical decline. The Bayesian study design allowed early identification of optimal dosing. The study supports the hypothesis that targeting soluble A beta protofibrils aggregates can alter the Alzheimer's disease progression. Through the primary endpoint, it was missed. The secondary findings justify continuation to the phase 3 trials. The strength of the study was innovative Bayesian design, improving the trial efficiency. High sensitivity ADCOMS tool to detect early cognitive changes. Consistency across multiple clinical and biomarker endpoints. The inclusion of biomarker positive AD patients was done to ensure target specificity. The limitations of the study was primary endpoint at 12 months was not met, and the imbalance in FOE4 carrier distribution due to mild trial protocol was changed, and small subgroup sizes limited to some interpretations. Volumetric MRI showed brain volumes reductions with unclear clinical significance. So this article followed the consort guidelines, and it followed all the guidelines. The item number 10, which tells how who generated and enrolled the participants was not clearly mentioned. It was partially mentioned. Otherwise, this article adheres to the guidelines very well.